final talk by Dr. Prakash Hazra. He's going to talk about the role of Vericiguat in heart failure.
Pranam, sir. The heart failure is a disease of the many presidents of the United States, and many of our colleagues have died due to heart failure, and many will die in the future if we do not take care of heart failure. It is sometimes first, sometimes frequent, many times forgotten, and many times is fatal. And these are the frequent flyers, and they come and go. So we have the opportunity now, those who fail the GDMT because of the side effects, or those who are on GDMT in spite of them, they are frequent flyers. The GDMT plus Vericiguat is an option. Now, defining worsening heart failure in 2021, it's not a rocket science to understand that ADHF is different from worsening heart failure. And for the first time in ECAC 2021, this term has been coined and because of this trial. So deteriorating clinically, deteriorating volume status, rising biomarkers, and crisis care of chronic heart failure includes increase in diuretics. Sometimes it is oral, sometimes it is IV, and it is basically a combination of de novo heart failure or worsening heart failure sometimes. As we move ahead with this kind of heart failure in the lifeline or timeline of any heart failure with reduced ejection fractions, the threshold for hospitalization comes down very much, and the drug response and the drug side effects, the day-to-day renal functions, all can happen. So we need a drug for this kind of people where it suits almost all group of people, all race, and all kinds of comorbidities. Each worsening heart failure event has a lasting impact on the patient's psychology, the quality of life, the fear, and the hospital-acquired infections and the other diseases in COVID era. Now, we know that the EF is very important to understand, not the GLS for the time being, because there has to be a goalpost, a target for every trial. And there were trials which dealt with less than 25% long time ago. And there were trials where ejection fraction was not known, like consensus on X-ray and MPAREG, we do not know the ejection fractions. So the parity came, the ejection fraction less than 45% in Victoria trial. We have a device trial less than CCM. So that means 45% a trial has got some haircut, improved ejection fractions or mildly reduced ejection fractions. We have trial now which are done on hospitalized patients like Victoria trial. And we have trial like non-hospitalized patients like Paradigm and APA-HF. We'll have more like Galactic. And this is the trial we are talking about. Symptomatic chronic heart failure with reduced ejection fractions. So don't get surprised by 45%. According to this trial, it is 45%. Now we know less than 40% is actually heart failure with reduced ejection fractions. So this chronic class 2 to class 4, 1.4% in class 4, prior heart failure hospitalization within 6 months, outpatient diuretic, systolic blood pressure more than 100 millimeter, clinically stable and off IV iron drops or IV drugs. This is a trial, one dose like dapagliflozin, 2.5 to 10 milligram, no run-in period like Paradigm. And this is a trial of composite. It's not like death and like a win and loss trial, like first you consider death and heart failure hospitalization. So it's a composite way of most of the trial, what we understand in 2022, that going by this way, you lose the implication of the trial. For example, if you have less CV death, more heart failure hospitalization, still a winner. And other way around, you can be also winner. So you do not know which one is contributing to great extent. This is the time to death, time to first, time to ACM, all-cause mortality. So it's a time-guided event. And if you consider with other trial or compare with other trials, so Victoria trial has got 47% diabetics, and beta blocker penetration was quite good. And let us understand the patient profile less than 3 months after heart failure hospitalization, 67%. 3 to 6 months, we are talking about a patient subgroup less than 6 months of heart failure hospitalizations in 84% of patients. In hospital initiation of this drug is 11%, and less than 3 months after IV diuretics is 16%. Patients could be enrolled in Victoria up to 6 months after heart failure hospitalizations, or up to 3 months after an episode of worsening heart failure requiring IV diuretics without hospitalizations. So these are the patients who had 3 drugs in most of the patients, and eGFR was the lowest in the industry or in the trial line. Victoria, we're talking only up to 15 ml, and Emperor reduced 20 ml. This is close by. DAPA-HF 30. So most of the trial, they stop at 30, but Victoria trial is the only trial which stops at 15. And many trials, they differ in the NT-proBNP cutoff. And if you have atrial fibrillation, your proBNP cutoff will be different. And this is the trial we are talking about. Is a targeted distinct population. This is new inodilator with much higher baseline risk. Like if you talk about the event rate, the placebo arm, 37 point, almost 40% event rate per 100 patients here. Whereas very good drug, robust drug like empagliflozin, dapagliflozin, we are talking about almost 50% less risky patients. And this is the diagram of positive outcome where 4 foundation ends. Mainly in this Victoria trial, the 3 drugs, SGLT2 penetration was very poor. So I would say where the 3 foundation ends, the Vericiguat begins with a bang with composite outcome, but no change in cardiovascular death. All-cause death was reduced comparison to placebo, heart failure hospitalizations. So among patients with chronic heart failure with recent decompensation, a novel strategy, a new inodilator of increasing soluble guanylate cyclase, which can make it better quantitatively and qualitatively. And it is very well tolerated. Now, this is the graph, and you can see the difference. And the annual NNT, like it is 10.8 months trial, very short trial. But even in that short period of time, that absolute risk reduction was 4.2 events per 1,000. Hazard ratio was 0.9. Now, if you see this picture, the cardiovascular death has not changed, whereas a total heart failure hospital has changed. And if you take the combination of this all-cause mortality, it has changed. But if you take separately, it did not change. So absolute risk reduction was an outlier here. Cardiovascular death was outlier in a different way. That means it is negative. Fast heart failure hospitalizations, again outlier, 1.6 versus 2.9, 4.8, and 3.2. So it comes in close proximity to Emperor reduced, and it is quite far away from paradigm HF, that is RA. As far as the secondary outcomes are concerned, it is still a tall tower on heart failure hospitalizations and far away from paradigm HF, DAPA-HF, Emperor reduced, collective HS. But these are again secondary. Secondary analysis doesn't have that much of statistical power or clinical significance because these are all secondary. Let's talk about NT-proBNP 2816 in Victoria trial in comparison to the other trial, which has got lower BNP, and they are different group of people. So if you go back to the history, every trial has talked about these biomarkers, and with time we are improving on the cutoff because we are getting more. We are getting much sicker patients, much more patients having comorbidities. So we are also learning that proBNP has caused a significant difference in the outcome. So how far you can go with the Vericiguat? We can go up to 8,000. The positive treatment effect on primary outcome evident for patients with NT-proBNP less than 8,000, 86% of the Victoria populations, further amplified in patients with NT-proBNP and less than 4,000, 65% of Victoria populations. For less than 8,000 picogram, the positive treatment effect of extended both cardiovascular death and heart failure hospitals is maintained. So you may ask why that if you have a patient who has got 9,000 proBNP, why this drug doesn't work? Perhaps there is not much substrate left for this drug to act at the level of proBNP in thousands, more than 8,000. So what is the timeline? It starts falling after 4 months, and it is consistently falling. And if you look about the predictive model for cardiovascular death and heart failure hospitalization, there is a model available now. And in this model, the proBNP is the most important factor, which has got C value or C indices from 0.68 to 0.72. If it crosses more than 0.8, it's very good. And if it crosses 0.90, excellent. And if you talk about the MRA, which a previous speaker has spoken about, MRA-in means hyperkalemia-in. MRA means the stoppage of the drug because of hyperkalemia, sudden cardiac death, pacing, and hospitalizations. The mRNA penetration in galactic HF 77%, DAPA HF 71%, and Victoria is 70%. Very good, very happy. And atrial fibrillations, you talk about atrial fibrillations, very important in heart failure. These are the people who are very sick. Ejection fraction 29 mean, 86% patient had less than 40% ejection fraction, 40% was in class 3, only 1.4% was in class 4. And what is the incidence in comparison to galactic? 42, paradigm 36, DAPA 39, EMPEROR 47%, 45%, good number, and these are sick people. Now, these atrial fibrillations not known in 53%, intermittent 20%, AF at randomization 27%, post-randomization AF group 1 and group 2 together 9.4%. That means new onset of AF was 1 in 10 at follow-up of 10.8 months. No prior AF was 6.4%. So who are these people? I mean, we are bothered about older, 1365 patients, stroke patients, CKDs, CKD patient, anemic, pro-BNP high, COPD male, less diabetic, less CRT, less ICD because of obvious reason, because in AF, this doesn't work. And patients with intermittent AF had the lowest use of triple medical therapy, minus the SGLT as I mentioned, and there is no effect at randomizations, there is no effect at post-randomizations, there is p-value for interaction is insignificant. And it's not a rocket science to understand that AF patients, they die early, they need hospitalization more frequently, but Vericiguat does not have a differential effect whether patient has got AF or no AF. But we know that in AF, many other drugs like beta blocker does not work, device does not work. So these sick man or sick people need some new therapy, that is Vericiguat. Intermittent had worse outcome, no rocket science mentioned. So this is the pictorial presentation of atrial fibrillations at randomization and after randomizations. So Vericiguat, Vericiguat 2.5, 5 and 10 milligram once in a day like SGLT2, no dose adjustment is required in CKD, age frailty, same dose in mild to moderate liver failure, no drug interaction with RNA, warfarin, aspirin, and 93% bioavailability with food or without food. And these are very good drug for these kind of clinical situations, as I mentioned, low BP, elderly, and device failure or failing on GDMT. But it is a costly drug, and it is it will be available in India. It works irrespective of the Europeans or Western European, Asia Pacific. So we have tried. We have some experience initially. So this works across the globe. And hypertension, 1, 3, 4 patients, and in hypertension, the first 4 weeks we get the maximum hypertension and the syncope. But after 4 weeks is well tolerated, and the p-value for interaction is not there whether you have hypertension or no hypertension. The beta blockers in hypertension, Dr. Bansal has spoken about. The DAPA HF 96%, EMPEROR is 95%, Galactic 94%, Victoria 93%. So these are the people who has got very good SOC, the standard of care. On the top of that, it's very difficult to reduce the cardiovascular death because most of the cardiovascular death is reduced by very beautiful 4 foundation fabulous drug, which we have discussed previously. So adoption is very good, almost 90%. RNA use or no RNA use, the penetration of RNA like empatropism 41%, EMPEROR 19%, and Victoria trial was 15%, that is 930 patients. So once we have more penetration of RNA, and these patients will develop hyperkalemia, somebody who develop hyperkalemia, MRA and RNA may not be introduced. Yeah, so this is a class 2B, and the results are very promising. This is the patients for, this is a drug for many people who cannot tolerate this, and this is very evident. Now, mechanism of action of Vericiguat is basically increases the quantitative and qualitative cycling GMP. Now, I believe that we have now uniform pharma code, the drug democracy. Every drug may not be born equal, but they have equal rights for the first line of therapy. Now, this is vertical from horizontal. Now it is circular. You can start anywhere with RNA, mRNA, SGLT2. The second line of defense is Vericiguat, overcaptive IV iron, and evaporated. And we are moving ahead with newer drugs, newer philosophy, the rehabs, LVAD, AF ablations. Everything is important, and patient's care should be a shared decision making, and you should give the best benefit of every drug. And adaptation may take some time. With that, I'd like to thank you for your kind attention.